я з свого боку хочу сказати декілька слів. Ви знаєте, що сьогодні дуже напружена програма. В нашому заході приймають участь президенти, колишні, нинішні, причому президенти з різних країн і різних товариств. Тому і почнемо ми з колишнього президента і Хансjoerga Леу і нинішнього президента Бурхарда. Але до чого я веду? До того, що ми не можемо, вірніше, ми повинні вкладатися в терміни доповіді, щоб ми більше, ніж потрібно, не затягували. Ну, я маю на увазі тих доповідачів, які будуть офлайн, наші. Тому що зіб'ється вся програма з різних країн світу. Ну, починається там Швейцарія, Пакистан, Південна Корея, Індонезія, ну і так далі. Я вже не кажу, там потім Сполучені Штати Америки. Це люди, які сьогодні на передовій. Можна подивитися на те, що є зараз, ну, саме передове. У нас дещо є, ну, дечого, може, у нас ще нема, але буде найближчим часом. Що там на зв'язку? Хансjoerg із Швейцарії, з міста Цюріх. Ви знаєте, що...
Can you hear me? Can you hear me?
Окей.
We start now the presentation on the concept of this endoscopic surgery. When we go back in history, we see that first ideas on endoscopic applications has been developed as early as 1806 by Bossini in Germany. You see here his endoscope that was a tubular system for the bladder inspection. This was a design then from what he has seen in his prospect. In the 80s of the 19th century in Vienna, the von Mikulicz technique for the endoscopy of the stomach with a rigid, like a sword technique application with the first time electric illumination. The problem from any kind of endoscopy, as already Boccini has seen, is illumination inside of the organ you want to inspect. It has been then a first lens toracoscopy technique with lenticular lens system by Jacobaeus in 1912. This has been the first applicable endoscope for thoracic and bladder application with illumination. We had then in Switzerland the Eugene Berger, knee surgeon, who adapted this Wolf-Jacobaeus system for the first application in knee arthroscopy. He had at that time a little problem with the bulbs of the illumination that was not very stable and had to be replaced several times during one inspection. In the field of surgery, we had the understanding of disc problems first in 1934 in the United States by Mixter and Barr. The first explanation of sciatalgic pain was already by Walter Dendy in 1929 for the prolapsed disc. The triangular application of needle techniques for Pott's disease was then introduced in 1948 by Carlos Ottolenghi in Argentina. He was an Italian working then after the war in South America. This was a blind technique, but it was the first application that could reach the intervertebral disc and the vertebral body by a triangular calculation. In Germany in 1952, it was Karl Storch that introduced the rod lens laryngoscope. Rod lens is not a lentiform system, it's like a bar of glass, and this has the big advantage that it's much more light conducting than the lenticular system. This was the laryngoscopy that he introduced. It was used especially also by the anesthesiologist to control the approach for the intubation. In the field of surgery, minimally invasive techniques has been introduced then for disc problems with chemopapa in chemical application, with the Otto-Lengi application techniques, and chemopapa by Lyman Smith in 1963. It was in use in the United States and in Europe up to the mid-70s. It was then abandoned by problems of allergic reactions. In Europe at that time, still maximal invasive techniques such as Roy Camille techniques was popular in stabilization and opening techniques. In the early 70s in the United States and in Japan, Kambin and Hijikata developed their system for decompression of the disc by a tubular system. They has been both fully independent from each other. The Japanese technique was a fine, larger needle techniques, while the American system that you see above is the combination of percutaneous decompression of the disc with an open posterior decompression. In Germany, in 1977, it was Walter Kasper that developed the microscopic technique that is still one of the great standards for any kind of spinal surgery, especially also today for larger exposure and decompression of the channel. In Switzerland, it was then Yoshinori Suesama, a Japanese that worked at Balgi's clinic, that went to the Congress of Kyoto and brought back in 97 the uniportal discectomy with the percutaneous approach from the Hijikata technique. It was applied at the Balgi's clinic then in the first years by enlarging a little bit the cannulas, and it was combined then in 82 by Adam Schreiber with the endoscopic control. There has been a full range of further evolutions with interbody fusion and later then foraminal microdiscectomy by endoscopy. You see here the biportal approach of the application then with the indigo carmine staining inside of the disc, to distinguish between migrated fragments and healthy tissue. This was published then in 1984 by the Hohmann book of Advantage in Surgery. There has been also some development with the application of rongeurs, forceps with sections, and angulated Storz-Hopkins modified with 30 degrees technology for the inspection of the intervertebral disc space. It was always a biportal approach, because from one side you had the optics and from the other side the instrument. So you had to work vice versa to decompress the posterior part of the disc. It has been also a learning curve there to learn that you have to decompress the posterior part of the intervertebral disc space. And you see here then in the later application of the biportal approach, it became possible to have a selective subligamentary decompression for such kind of non-migrated subligamentary herniations. There has been a learning curve also in the results. We had some root lesions seen with 6 to 1% sensory irritations, 15 to 3%. The larger percentage is in the larger series. So it had also be learned to how to apply this. In the technique of removal of disc tissue, we had then also development in Austria by Peter Ascher with the CO2 laser applications. It was again in a blind technique, but it was the first application to remove material of intervertebral disc space by laser. We applied then in Balgris clinic several lasers such as neodymium and holmium, but finally we had to realize that the laser is not more efficient in this tissue removal than mechanical adapted tools with angulating mouses and things like that. So the laser had also dangers. You could burn also across the anterior containment of the disc, and this was a problem that was also published by Ascher in Austria, that the risk of heat damage of the laser has been considerable. This was better than with the holmium YAG laser because he had a very short range of thermal effect, but the efficiency of removal was not comparable to mechanical tools. When then the decompression took place in a little bit more surgical teams, it was being John Shepherd in 85 in Great Britain in Hastings that developed interbody restabilization after uniportal tubular discectomy. He introduced a bone pick from the iliac crest that he implanted then at the end of the procedure in the intervertebral disc space. It was not possible at that time to open the end plates, that you could not get fusions, and this bone picks that was implanted then was reabsorbed quite quickly. So there was not a very promising technique, but the principle was genius to use also endoscopic technique for fusion technique. At the Balgris clinic, we used in these 80s the external fixation device by AO, developed by Magel in St. Gallen. It was the first percutaneous way to realign and distract lumbar spine segments. And we used that for traumatology, and then we applied this also for probatory distraction and realignment. And then when the patient has been pain-free after distraction and realignment, then we tried a way to get the fusion. Now we had to open the end plates that we could have a good bleeding bone bed for the bone chips to get the fusion. Here you see then the application of this eccentrically milling cutter that opened the end plates down to the bleeding bone. And after that opening, then we implanted the fresh harvested bone chips for the interbody fusion. The external fixator was still in place, as you can see here, and this is the application from one side with the optical control and from the other side with the biportal technique with the milling cutter that goes deep here to the bone structures and removes the end plate. It was quite a successful technique. It was less harm for the muscles in the posterior part. Still, the pinnings from the external fixator has been to consider, but it was not the large opening that you had in open surgery. Here is an end result after more than 11 years. You see here the interbody fusion in this patient with spondylolysis. And what is very interesting is that the adjacent segment disease that you fear in the conventional technique of intervertebral fusion was nearly not visible because you did not harm the posterior part of the stabilization apparatus with the muscles. So the main goal and the main advantage was the avoidance of adjacent segment degeneration. Obviously, the external fixation device has not been very attractive for the patient. So in the later years, it was replaced then mostly with the sextant system, similar techniques to avoid this 6 to 10 weeks of external fixation device. We use then this modified endoscopic to use it as a coaxial uniportal technique. It was again the Storz company that modified urological endoscopy first time in 91 to have a working channel in combination with the optical control. This was the first uniportal direct access to a migrated fragment in the foraminal area. We had to learn also to apply this technique. So you, by the anatomical facts that you have the ganglion here in the part of the foramen, you might start always in the lower part of the intervertebral disc, in the Cambin triangle, and then work up to the foramen to avoid squeezing of the root and the ganglion that is pushed up by this such migrated disc material. Here is the typical foraminal application. You can reach with the endoscope about up to here. It is not the way from lateral part for the channel decompression. This is then a technique that I will show you that is presented by Rutten. Here is the application with the needle and the enlargement tubings, and always start in the lower part and work up to the upper part. Here you can see some application with such migrated fragments before rinsing, then after rinsing and prepared for extraction. And here the extraction of the fragments with this Storz system, which is in use since 96. Here you can see the clinical applications. Here a workup in the subligamentary area. You see here above the thecal sac and the decompression in the subligamentary area in the mediolateral to medioforaminal part of the intervertebral disc space. We had to learn then also to manage some bleedings. In the first years, we used the high frequency coagulator from Elman, and now as a standard we have the cooling liquid for irrigation that with a 4 to 6 degree Celsius makes a vasoconstriction, and hardly ever we need the coagulator. We had also some learning curves with this technique, obviously, and we have now a standardizing by 70 to 80% of good results in the later series. When you have such evolution, also other people are working on that. You see here Fontanella in Italy, who worked for the cervical spine with a combined system for the cervical decompression, transdiscal from anterior. It's quite a nice technique, no way for restabilization. Then you have Jean Destandron in France, who presented his decompressing system with a ovaloid tubular. This was the first system you could apply in the interlaminar and in the lateral foraminal area for endoscopic systems. It is a kind of minimalization of the micro technique by applying with an endoscopic system in the tube that was later on also further developed by the colleagues in Germany. You see here the preparation of the herniation and opening and extraction of the material. It's quite comparable to microdiscectomy with a more minimal applicator. Then in Japan, we had the people of the group of Yoshida who developed the tubular system with also a coaxial endoscopic technique. This is a modification of the Destandro with a smaller tubular system for the interlaminar approach. We had then Sebastian Rütten in Germany who further minimized the tubes. Also for the interlaminar approach, L5S1, when you have a larger intervertebral disc space, you can use that quite securely. Very elegant technique, and it is difficult in the mid and upper lumbar area when you have not the direct access to the disc because of the anatomy, and then you must work up the removal of bone material, which can be a bit critical with this very slim system. We had then also in Japan the group of the Desawa, who in the early year of the century developed this burrs with round and longer tips. This helped to enlarge also the foraminal approach for foraminectomy by endoscopic technique. These techniques, of this drill burrs is now in application also in many of the today's applications. We had then the group in Germany by Joachim Oertel, who is the teacher of Professor Burkhardt, who developed in the early years also of the century his tubular system called Easy Go in several generations. It was had the advantage that it has stepwise enlarging tubes that you can use also conventional instruments for the interlaminar approach. You can also have a translaminar approach when the application goes to the relative site. You have here the combination of the endoscopy, which is fixed on the tube. Here we have this. You see here the application of that system with the drill bar opening the approach in the interlaminar area, removal of the herniated disc. Professor Burkhardt will later on show this technique. This is the application then in the OR room with conventional forceps, and at the end then the removal of the migrated fragment that is more comfortable than with purely endoscopy, because you can work up with the larger instruments than with the uniportal approach, to which has a channel which is only about 4 millimeters. This is much more easy for extraction of the fragments. When you summarize all this experience, you can see that today's practice of endoscopic surgery covers about this area for the transforaminal and foraminal applications, and interlaminar by the tubular system, like Easy Go of the mediolateral to centrocaudal techniques. There is still a field of application in the interpedicular room, which is probably still easier to use with the conventional microscopic techniques, because with the tubular system you lose more time, and the overview with the micro in this area when you have to decompress the bone is probably some more practicable. When we look at the meta-analytic analysis of the results of the different techniques like endoscopy, microdiscectomy, open techniques, and conservative treatment, at the end of about 2 to 3 years, you get the similar results. But you see that with the micro techniques and the endo techniques in special, you get quicker to the good end results. And at the end results, you reach about 75 to 80% maximum, because also with all kind of techniques of applications that you can apply today, you cannot change the progress of the degenerative disease. So today you must have a choice, the most adapted choice for the problem that you have to resolve, and try to minimize the damage. So the policy today, do not do everything with the same techniques. Select your procedure to the problem that you have to resolve, and select also the good time. It's the best time to use these techniques before the neural damage is fixed. So about the window of application of surgical technique should be in the first 4 to 6 weeks to minimize the long-term damage of the neurology. So be smart, do the right thing, done with the right technique today. Now, it's my great pleasure to have contributed to this meeting, and I thank the organizers for this really international meeting in Ukraine in these difficult techniques, and I wish to you all, and especially to Ukraine, a full luck for the future. Thank you for your confidence.
Thank you very much, Professor Leu.